Hi, I am so elated in meeting you this 3 p.m. program 3 Point Medics. We have been learning about prothrombin and APTT. Just I want to highlight few case scenarios we have witnessed where the PT and APTT played a major role. 1 week before, 44 years old male patient presented with high grade of fever with tachypnea. The fever was associated with chills and dry hair, and there was burning sensation in the urine, obviously signaling the evidence of urinary infection. So after drawing blood and urine culture, patient was started on broad spectrum antibiotic. Since patient has fever, probably it may be a suspected or documented evidence of infection, and patient had tachycardia and tachypnea, and there are derangement in the blood parameters pointing out the diagnosis of sepsis. So during evaluation, the patient's WBC count is around 23,000, patient's platelet around 80,000. So we were thinking in terms of sepsis. Patient's BP was around 70. So we were really contemplating about the diagnosis of septic shock. But before you diagnose the septic shock, first you have to resuscitate the patient with adequate crystalloid, preferably 0.9% normal saline, 30 ml per kg over 2 hours. For example, if patient weighs about 60 kg, then 60 into 30 ml, 1800 ml, approximately 2 liter 0.9% normal saline was given over 2 hours, but still patient's blood pressure around 70 to 80. So we started him on noradrenaline to propel his blood pressure. So definitely it is a case of septic shock. Since the patient has platelet 80,000, we were not content with thrombocytopenia alone. Patient was proceeded with prothrombin and APTT. So both PT and APTT were prolonged. The PT INR, INR is 1.9. Patient's APTT was around 60 seconds. So indicating there is enough evidence of activation of coagulation pathway. So patient underwent fibrinogen level that was drastically reduced. Fibrinogen degradation products FDP got elevated. All these were signaling the evidence of existing DIC. So when you diagnose DIC in the presence of sepsis, then probably that condition carries high mortality. As I told you earlier, when prothrombin and APTT both are prolonged, you have to think of chronic liver disease and vitamin K deficiency, antiphospholipid antibody syndrome, and disseminated intravascular coagulation. But here the situation was very much apt for the suspicion for DIC. Then we evaluated further with PT, APTT, FDP and serum fibrinogen level and so on. So you should not be content with thrombocytopenia alone. When somebody has thrombocytopenia, do PT and APTT to elaborate further involvement of coagulation pathway. If only platelet is decreased alone, then you can think of some form of compromise in platelet function alone, or otherwise you have to always explore how his coagulation pathway. 1 week before, Dr. Aruna, senior hematologist, she shared one child's history such that child was referred to her for bleeding following circumcision. Child underwent immediately prothrombin and APTT and platelets. Platelets are normal, but child has increased APTT and normal PT. As I told you earlier, normal prothrombin ruled out factor 7 deficiency, but increased APTT indicates one of the deficiency of the rest of the clotting factor. So the most important clotting factor deficiency congenital origin is 8th factor deficiency. Then child was diagnosed to have 8th factor deficiency or otherwise called hemophilia. So how really it is helpful in evaluating PT and APTT. And one more patient 3 days before presented with increased APTT and normal PT. Then lab person informed me, sir, PT so many times we repeated, PT is normal, only APTT got prolonged. I am so worried about my procedure. Am I on the right direction? He asked. Then I consoled him, you don't need to worry, patient has been receiving heparin infusion, that's why APTT alone prolonged, PT remains normal. So these are the few cases you can explore the possibility of prolonged PT and APTT. Thank you.